The MedBricks webcast is focused on bringing distinguished Indians and others from diverse fields of science, medicine, technology, and philosophy to learn from each other and to create a new understandings and foster new ideas related to healthcare. Hey, good morning, India. Good afternoon, someplace, and good night, late night in Europe, and good evening in California, and then East Coast sleepy time. Welcome you all. My name is Ramana Anamraju, host of the webcast, MedBricks webcast. Thank you. I got a great responses nowadays. Thank you so much. So we have a very distinguished guest. He's a professor of he's a professor, medical director, a pathologist. So yeah, I'm going to introduce you. But the program is we are a healthcare media channel. We are we are on live on several media channels, and then our goal is to promote the foster the new kind of technologies and the healthcare all mixed up polymath physicians. I want to be a best ambassador for physicians. That's our goal, for the to learn more curious mind for curious minds expand their minds to different areas of the subjects so they can understand better with the new innovations and technologies. So, without a further delay, let me introduce my friend. He is Dr. Krishna Tangella. He is from neck of my woods, same tribe. As I said, that he is a professor and he is a teacher in the University of Chicago, Illinois, Urbana. Then he is a medical director for the pathology lab. So pathology is actually a bridge between science and medicine. They're doctor's doctor. So who will ask him his ideas about that? What does the pathology do exactly? That's very important nowadays. They're playing a critical role. So without further delay, let me introduce Dr. Um, um, Krishna Tangella.
Thanks, Mr. Anamraju. First of all, thank you for having me here. I have seen multiple videos and live shows from your past sessions, and I find you to be very engaging. I find you to be a keen listener and a very curious mind, and you have put on a really good show with very distinguished people. So it's a great honor to be here talking to you, and hopefully I'll be able to kind of shed a little light of what pathologists do in healthcare and how they fit into the value stream map in the healthcare delivery system. Um, Thank you for having me here, and congratulations on putting up a really good show.
So, what is a pathologist? A doctor's doctor, he said. I said, what is a doctor's doctors do? What they do, the doctors connect with you in what way? They first, what is your touch point between you and the physicians?
Yeah. So many pathology field of pathology is often misunderstood and misinterpreted in many ways. Many people compare, or at least what they see on the TV shows, which is CSI, when we do forensic medicine, forensic science type of shows, and which is very glamorous. They seem to have all the answers on the show. Um, the real practice of pathology is a little different. I would say that there is a component of forensic pathology with autopsies and trying to discover the cause of death. But that is a very small component, and we have specialists who actually do that as medical examiners and coroners. Uh, in vast majority of cases, a pathologist, there are about 20,000 pathologists in America, and about 450 of them graduate every year. So not a huge number of them. When they come out to the workforce after 4 to 5 years of 4 years of residency and then year to 2 years of fellowship, there are two major components, I would say, of field of pathology. It's a pretty vast field. Unlike other countries where you have an MD in microbiology, MD in pathology, MD in forensic pathology, we have MD in biochemistry, MD in physiology, MD in anatomy. In America, a MD in pathology encompasses all these fields. And when a pathology graduates comes into the work field, there are two major components. One is anatomic pathology, and other is clinical pathology. Clinical pathology is the science where you have a lot of machines that run blood tests, body fluid tests, and the pathologist guides, supervises, and make sure the testing that and the results that are being put into the EMR are valid, accurate, and reliable. So that's the role of a pathologist. And you probably know that 80% of a healthcare chart is laboratory medicine and pathology. And so pathologists play a very integral part in that area. The second component of a pathology practice is anatomic pathology, which consists of tissue biopsies. Um, Anytime a surgeon or a clinician uh, takes out a piece of human tissue, they send it to pathology for analysis. And there are, each part of the body has their own experts. You can have neuropathology for brain, you can have lung pathologists for lungs, GI pathologists for GI, skin pathologist, dermatopathologist for skin, so on and so forth. Again, these are specialists. Um, More often than not, uh, the general pathologists who work in community practice cover all these areas on their own. And they ask for help from academic medical centers when a difficult case comes along to an expert in that particular area of pathology specialty. Um, anatomic pathologists also uh, do autopsies. They do cytology. Some of them actually do fine needle aspiration procedures themselves uh, under ultrasound guidance if they are trained. And some pathologists are trained to do bone marrow biopsies and so on and so forth. So a large part of pathology practice is oncology service, where we try to classify tumors and diagnose tumors.
Dr. Tangella, as we are facing a pandemic, we are going through a pandemic. What kind of pathologies you saw during the pandemic? Particularly COVID, that's particularly affected lungs. So, what kind of pathologies you were finding very curious for public, or other physicians?
Sure. So during the COVID time, we saw a variety of pathological issues when it comes to how COVID-19 affected humans. Um, we, vast majority of us, believe that it is a respiratory infection affecting lungs, uh, but COVID, uh, virus affects different systems in the body, and it affects uh, specifically it affects your vascular system. So we have found curiously that the virus can cause coagulopathies, resulting in uh, thrombosis, DIC situations, which is disseminated intravascular coagulation defects, um, and it also affects the inflammation coming from the viral infection can affect pretty much any organ in the body. I have seen multiple cases reported in my hospital where the viral infection has resulted in myocarditis, which is the inflammation of the heart. In one case, there was actually, uh, arrhythmia because of the inflammation of the heart. So interesting. We are still understanding the whole this the clinical spectrum of how the virus has affected the body. Uh, Again, what
It's
looks
very
to us,
interesting.
yeah,
Yeah.
what looks us to us is the lung infection, which is, but I would say it's much more than that.
It's much more complex and much more long. Now we are understanding the long COVID, a lot of other organs are affected. So,
Yes,
second biggest disease, all that the number one disease of all is the cancer. What kind of a role pathologists play in cancer diagnosis, treatment, and the prognosis kind of areas?
sure. So, um, so very, it's not a easy answer, but I will take a little time to explain. Um, I'll take you back 20 years in time, 20 years in time, where a biopsy would have been done of a tumor, um, and the pathologist will look under the microscope and answer the question, is it cancer or is it not a cancer? The second question you would see answered on a pathology report is, if it is cancer, what is the histologic subtype? Is it an adenocarcinoma? It is a squamous cell carcinoma? Is it a lymphoma? And so on and so forth. So you got an answer whether it's cancer or benign. And if it was cancer, you got what type was it? And based on that, uh, the oncologist and the care team would treat the cancer accordingly. In the last 20 years, every year I've seen tremendous progress in cancer treatments and cancer diagnosis. So the kind of information our clinicians are requiring now from a pathologist's biopsy specimen is much more than just cancer or not a cancer. So they want information on prognosis. Prognosis meaning, how bad the tumor is. And these are extra markers that have been well characterized. These are special studies that can be performed. And so that is one. Recently, in the last 10 years, um, rapid evolution is occurring in predictive markers. What I mean by predictive markers is the pathologist on the tissue would perform additional specialized testing, which will help clinicians give a specific treatment or avoid certain medications and hence avoid unnecessary chemotherapy. So, a biopsy now gives you information on diagnostic areas, prognostic areas, and predictive areas. And with the advent of molecular testing and gene sequencing, next generation sequencing or NGS, or even molecular profiling of the tumors, we are able to get target information against the tumor um, in a variety of clinical situations.
There is a, as you know, there is a lot of times there is a huge problem with the misdiagnosis of cancers. Where that occurs is at the primary care level. They forget about it. They mislead. They understand a different way. Or the pathologist, there is a something fundamentally science is not progressed yet in the areas of diagnosis and earlier diagnosis, for example. That's how do you um, besides imaging in pathology side, anything going on in that diagnosis side more in these advances?
Sure. So you raised two issues here. One was misdiagnosis issue, and the other was early diagnosis and screening tests. Um, I would say that uh, the pathologists and the pathology world has done a fantastic job in the laboratory setting uh, to avoid misdiagnosis. Misdiagnosis occurs very, very rarely. There's a lot of quality assurance programs that the College of American Pathologists, in collaboration with the local pathologists themselves, have come up with the systems in place. So when a misdiagnosis occurs, which you hear it in the news, and when you hear it, it becomes a pretty big news, is the wrong breast got resected, and there's no cancer in it, or sometimes two specimens get mixed up, um, and you get a cancer diagnosis on a wrong patient. That happens. So I would classify, I would classify the causes of these rare, I would again emphasize this, are not very common, rare misdiagnosed type situation as into three buckets: pre-analytical variation, analytical variations, and post-analytical variations. Pre-analytical variations is there are two patients getting operated before the specimen comes to the operating room, to the pathology lab. The two patients are getting operated in the operating room, and the specimens comes to us completely mixed up. So that's pre-analytical variation. Sometimes a wrong label gets put on that patient container. So that's pre-analytical variation. Analytical variation happens when the pathologists themselves either looks at the wrong slide, because there are so many slides sitting next to the microscope. uh, they look at a different slide, or sometimes the tissue gets cut on a wrong labels, slide labels. So that's sometimes the pathologists miss the diagnosis. They look at the slides and genuinely they look at it and they believe it's benign, but there could be malignancy there. So it happens rarely. Post-analytical variation, of course, are much less common, but sometimes you have a pathology report getting scanned in to the EMR. A wrong report gets scanned in to a wrong patient, and you can have a cancer report getting scanned in to a completely wrong patient, and when that happens, that's called the post-analytical variations. So those are the errors that occurs in pathology. Not very often, thankfully. When it happens, it's a very serious situation, obviously impacting healthcare, and we pathologists take it extremely seriously. The
Despite
second,
all,
yeah,
despite all the misleading, misdiagnosis or anything, but they made a leaps and bounds progress in the diagnosis wise, prognosis wise, and then predictive wise. You did a enormous great job in the pathology. Came up with wonders, in fact, in that sense. But let me ask you the other part of the medical side of it. So when you're in the cancer is of one of the things, and then you're talking about the predict. Let me talk about a little bit about the predictive side. Is it a more a mathematical side of it, or the biological side sample, and then you add a mathematics to it to analyze the predictive model? Or just because I'm IT with IT people are there watching, so that you could give us what is that involvement in the predictive model?
sure. So again, a very insightful question. Um, Currently, in vast majority of scenarios, we look for next gen. We do gene analysis, looking for specific targets for which we have um, for which we clearly have treatments for, and these are FDA approved treatments. So we develop a laboratory assay, um, a molecular assay, and test for this target. If it's positive, then the treatment is given. If it is negative, then the treatment is avoided. Um, what you're talking about is when you have a huge amount of data from the genetic data, gene sequencing data. um, we are using AIs now and machine learnings to look for correlations,
Mm.
um, and looking for a pattern which helps us understand the biology of the tumor. Um, I am not aware. I work in a community healthcare setting. We have not had that technology come to us yet, but I'm sure my colleagues in the pathology academic world are working with AI and ML to analyze this huge amount of genetic sequencing data and looking for cause effect relationships. And especially when you have this ML and AI integrated to clinical data, uh, we will be able to come to understanding what causes cancer. And remember also, not all cancers are the same. Uh, Individuals with cancers, they have individual genetic defects uh, that results in that tumor being formed. And so when we say lung cancer, even if two individuals have squamous cell carcinoma of lung, the biology of the tumor will may be very different. And that's where we have this personalized medicine comes into play. But you are absolutely correct. The next evolution of pathology world would be to crunch this tremendous amount of data. And this data is just not created from just tumor cells, but they are also from the whole genome. People are getting 23andMe, Ancestry.com, and there's a voluminous amount of information out there, which is getting aggregated. At some point, the data scientists will start connecting the dots, looking for cause-effect relationships. We will understand a lot of conditions and the biology and causation of them very, very soon.
In, you're not a neurophysiologist, a neuropathologist, but I'm going to ask you something about brain. Have you seen the particularly people who take drugs like a cocaine, alcohol, all those people? Do you see a particular anatomical pathology that is different than that? Is it? Do you see anything that makes you think that these are things that are affecting in a profound way?
Oh, 100% yes. So I'm not a neuropathologist, but I've done autopsies on the brain. And when we have individuals with a long-standing chronic drug use, and when you look at their brain and look at the blood vessels, obviously, the blood vessels are affected by cocaine because of vasoconstriction, and chronic vasoconstriction may result in brain atrophy. So it is a well-known fact that uh, the illicit drugs usage does result in observable um, changes in the brain tissue under a microscope. 100% yes.
With the excessive alcohol, also alcohol plays a role in that.
Oh yeah, absolutely. Alcoholism, chronic alcoholics have a certain pattern of brain pathology that clearly is identifiable. Yes.
Interesting. Let us talk about shift from the diseases to well-being. Now, precision medicine. People now they want to know more about the what they like to, what kind of medications they need a personalized one, what kind of a food they want to eat. Is a well-being now is taking a front and the center nowadays. So let us give. Can you give a little bit about a pathology's role in that area?
Yeah, I'm not sure how much a pathologist role would be in health and wellness from that arena, but uh, since if it touches the laboratory, uh, certainly we get involved. But also, I would tell you that of all the fields of medicine that we have, pathologists are the gatekeepers of research and advancement of science and biologic understanding of diseases and conditions. So there is a significant proportion of the pathologists who, after getting trained as a pathologist, end up running their own research laboratories and focusing on certain diseases and conditions. So uh, a lot of my colleagues and friends are top-notch researchers in, University of California, San Francisco, at St. Jude's Hospital, um, Mayo Clinic, doing some fantastic research, also at Northwestern. Um, so when it comes to precision medicine, uh, the world of medicine is going that way for sure. Um, we have lab tests now which help you understand the metabolic pathway the body has for processing certain medications. Um, Cytochrome oxidase pathway in liver can be analyzed in the laboratory, and it'll give you a clue whether you are a fast processor or a slow processor for certain medication. And accordingly, the dosage of the drugs and the drug interaction with other drugs um, can can be ascertained in these individuals. So adverse drug reactions, drug compatibility with for side effects, processing and dosage of medication, all that is part of precision medicine that a pathologist will be able to help out through laboratory testing. Then you used the terminology of wellness when it comes to gut science. And that is an absolutely field that is growing so fast. The gut biome has got a lot of focus on research and researchers these days. Um, there have been well published studies which have shown that altering your gut biome results uh, in uh, making better your chronic health conditions, such as ulcerative colitis, psoriasis, rheumatoid arthritis. So there's some correlation to your gut biome to your chronic conditions. Um, and I
Did
expect
you
that.
two pathologists do diagnose that you do anything on the gut microbiomes? You that's your job, and to recognize what kind of a microbiome structures are there.
So we can do obviously, rectal, stool cultures and let you know what kind of biome exists, right? Um, but this is more of a molecular science, I would say. We don't do routinely in our laboratory, in our community based laboratory setting. Uh, I'm not aware of what happens in academic center in this area. This is an evolving field. Especially when I trained, there was no training for me to uh, to understand this gut biome and how to test for what is a good gut biome and what is a bad gut biome. But I also know that someone who has Clostridium difficile diarrhea, and especially refractory Clostridium difficile infection, uh, stool transplant is the one of the treating mechanism for them. So uh, so I'm aware of that, and that does occur in my hospital occasionally. So I'll read up a little bit more on that and get back to you.
That's right.
What a
I
pathologist would be able to do.
I interviewed a Silicon Valley executive who started a big, huge investment with the Biome project. Mr. Naveen Jain is a Silicon Valley executive, started his own lab, microbiome testing lab, and he's claiming that what kind of foods he can eat and what foods suit for you. But I used to work for actually a genetic company. We used to test the Plavix, the anti-Plavix drug to CPY19 or some absence of the drug, and show how liver metabolizes that particular drug, and ultra metabolizer or their poor metabolizer. We used to recognize that, and we used to give reports to the doctors. That is a very valuable, in fact, at that certain times. So um, I'm glad you showed some light on that one. So pathologists play such a critical role. We misunderstood long years, what they play, because they are behind the scenes. They're like a movie directors of the movie. We don't see them. You don't see them. Now we are now, people are paying more attention to the CSI, and also this is a well-being side of it is they're playing a role, and then the cancer detection and diagnosis and treatment and prognosis, all those things, they're playing a critical role. People are paying much more attention to pathologists now. It is a truly honor, Dr. Krishna. Please stay. I'm going to present a presentation, and then I'll come back and ask you a couple of questions about India. What is the pathology is going on in Indian side? What things they can do improve? I may ask you a question in our back hometown. Just
Sure.
give me a minute. I'm going to present you my things here. Um, so that is that Dr. Krishna Tangella is a really truly learning. But I'm going to talk about the subject is the insurance companies, how they work. A lot of people ask me that, in Silicon Valley, when I used to live in Silicon Valley, the first question is, oh, who pays for it? And somebody, I have invention, I'm going to revolutionize the world, revolutionize the healthcare. When they used to say that, I used to ask them, what role they play. So actually, there is a saying that this is Richard Feynman said that if you think you understand quantum mechanics, you don't understand quantum mechanics. If you think you understand it, really you didn't understand it really. So what is the final conclusion? You don't never understand that quantum mechanics. So same thing. If you think you understand insurance, you really never understood the insurance. Really, that's what it is. So it is still complex. 30 years I've been in that industry, inside, outside. Still, I'm get confused about that industry. So it's a but anyway, I'm going to give you just a rundown of the basic stuff, and then you can add and learn more about it on your own. But the American healthcare system is basically the first and biggest healthcare insurance run by the government. United States government run the two biggest insurance companies, Medicare and Medicaid. These are two programs that are the huge that surpasses every other insurance company. So Medicare and Medicaid, I'll tell you about it. And then second part, the other insurances, private insurances that they are there. So in the private insurances, you see a lot of them that you see paying from the pocket, or you see insurance companies, the Blue Cross Blue Shield, or the private insurance companies, or company insurance pays for that. That is the private insurances. Self-insured is like paying cash. I just pay for the cash health savings account and all those things. I'm going to talk about a little bit more in detail about a little bit about quickly. So Medicare is, let us talk about the Medicare first. You have to understand insurance, you have to understand the Medicare in the United States, because Medicare is like a Bible. So all the other insurances follow Medicare guidelines usually. So the first thing is you have to understand what the Medicare thinks. That is the first thing. It is a federal program. It is 65 or older people are qualified for the Medicare enrollment. So Medicare is age is based on age. That's what it is. So there is a four parts to the Medicare: Part A, Part B, Part C, Part D. Part A is hospital visits. Most of them are hospital visits are run by Part A Medicare. Part B is the doctor's visit. When you go to the doctor's or if you want to get a MRI scan, or Part B or those kind of things. Part C is the Medicare Advantage plans, HMOs, ACOs. These are all Advantage plans. It's like a new invention of insurance plans. And then Part D is a prescription drugs benefits. That's they all that the overall insurance plans of the Medicare. So when you understand this, usually then it applies to all the other insurance companies. That's why everybody wants to get the Medicare approval first. That is the key. But let me explain a little bit of Part A. Part A is hospital visits, is a DRG, based on DRG, diagnosis related group payment system. It is a diagnosis related group payment system. Dr. Tangella was telling me I need to talk slow. I'm Indian, came from southern India. We talk fast. So I'm going to slow it down. So drug-related group payment system is a system that is played by condition. For example, normal newborn, they pay a particular $1,500, for example, for the entire birth. That's so the hospital gets paid for that. For the normal birth, so vaginal delivery, heart failure, they have a certain reimbursements for that. Complete heart congestive heart failure, psychosis. They have a different things. They cesarean section, they pay a separate fee. These kind of things you have to understand how they pay. DR is based on a DRG. It's based on a drug-related ICD codes 10 and ICD codes 10 and ICD 11. 11 is a more of a global thing, but basically ICD 10 is a ICD is International Classification of Diseases. So if you say if you talk about a disease in Boston, if you go to Hyderabad, India, they're talking same thing. So ICDs talk same language, universal language of the diseases, irrespective of which country you're in, what place you're in. So the next one is the Part B, that is CPT, is based on current procedural terminology. So that's if you have an X-ray done or MRI done, there's a CPT code there, 90035 or whatever it is. The code there is connected with the ICD code. The reason you are getting MRI done, you have a consistent headaches, it didn't go away. So they want you to get an MRI. So consistent headache is ICD, something they come up with the ICD code for that, and then you have to use a CPD procedure for the MRI with the contrast or not, no, not contrast, whatever the situation is. That is the gets paid by Part B coverage. If you go to the doctor, that is covered by Part B, doctor's visits. So Part B is basically outpatient. For example, 99203 is an outpatient office visit. If you try to remember what is the difference between CPD and ICD, CPD is usually they have 5 digits, and then ICD is a decimal points. That's what I used to remember. They may be changed quite a bit on that one, but at least I'm giving you some idea about that. So if you get a cough or cold, you go to doctor. He gets paid by the CPD code, okay, office visit. Then there is a several classifications of the office visits. Don't worry about it. So let me go, yeah. The next one is yeah. Part C is a Medicare Advantage plans. So HMOs, IPAs, ACOs, HMOs, Health and Maintenance Organization, IPAs, Independent Physician Associations, ACOs, Account Care Organizations. These are all kind of a plans that they came up with to reduce the risk. They say for example, if you are in a town of, say, small town in Urbana, Illinois, so you say, I will take all Medicare patients, I'll take care of them, and give me one check. I will take the risk, and the Medicare Advantage plans is make a negotiating deal with the insurance companies and say, give us a flat check. Who will manage all their insurance, all their health care. That is a managed care basically. So they have a different versions of it. I will explain to you in the ACO, account care organizations, same thing. IPAs, they used to do the same thing. I used to work in all three settings. In fact, I was involved in all three settings. They're all different versions of managing the risk and a risk itself. So they are making a negotiations with the insurance company itself. That's what the HMOs and IPAs and ACOs do. That's Part C. Usually, that is a Medicare Advantage plans that you can apply to the commercial insurance also. Part D is a pharmacy benefits, drug benefits. They used to have a donut thing. There is a, even it's hard to understand even for the pharmacist. It is a complex system. But anyway, pharmacy benefits are run by the Part D of the Medicare. Now the next one is Medicaid. Medicaid is a state run, is based on income. It's not based on age, it's income. So hospitals and doctors visits and everything is get paid by the Medicaid. That is Medicaid is run by states. In California they call Medi-Cal. So usually public aid. This is public aid. They have different names, but mostly Medicaid and Medi-Cal. And that's two names. So basically, Medicaid is a income based system. There is a sliding. So some people don't even fall between the Medicare and Medicaid. Then they have a sliding income scale. That's they do in the federally health qualified centers. They take care of those people if you don't have insurance. But let me go to um, the next is Medicare and Medicaid carriers. This is a technology. People are watching it. This because this is the one I wanted to give a lesson to the introduction to the technology companies. So actually, technology companies used to be carriers for Medicare, Medicaid. IBM used to carry Medicare. Still, they do in California, Medi-Cal. They run Medi-Cal. EDS, Ross Perot used to run the EDS. He used to run the Medicare and Medicaid programs actually. So a lot of technology companies run this Medicare. They are Medicare carriers. Means they don't. The government doesn't run the program. They assign to these technology companies run the program. Now they're doing Aetna, United Healthcare. They do the same thing now. So there are different players in this one. So the carriers are different, but they have to follow the same still federal guidelines. So yeah, so there is a private pay. Is a basically premiums. Your company paying the premiums. There is a health savings account. So what they say, they take some money, you put some money there, save that money, and the company puts some money there, and then you can use that money for $2,000 a year. Particularly, it's very popular in Silicon Valley. Suppose they want to get a things are not covered by insurance company, they can use the health savings account. They need a say psychological counseling. They need, if it doesn't cover, then they can use the health savings account to cover that. So it's very popular in the companies, and particularly in the Silicon Valley areas and technology companies like that kind of savings accounts. So there is a payment models to providers, how they get paid, doctors, labs, every, in the United States, you, whether you know or not, but the entire budget of the United States healthcare budget has to be signed by the doctors. That's a period, direct or indirect, they have to sign it. Okay, so there is not a, if they don't supervise, they don't get paid. That is a, people don't know this. That's basically the doctors are the ultimate signers of the entire budget of the healthcare system in the United States. So there is three kind of models. Fee for service model means if I go to a doctor, I get an office visit. That's a procedure code I was mentioning, CPD codes. I get paid. The doctor get paid. That's much money because we are assigning the rights to collect to the doctor to collect the money. So that he gets paid by the fee for service. So particular service, a CPD code, they get paid for CPD codes. Not for the diagnosis code, they pay for the CPD code procedures you do in the doctor's offices. There is another model, capitation model, is that per month per member model. That is like you have 1,000 members in the thousand in Urbana. Suppose you have 1,000 people are there in the Medicare. They pay, the insurance company says that we pay you $1,000 a month per month per patient. You take care of all their problems. That's called capitation. There is a several models of it. Full risk capitation, partial risk capitation is a very, and combo hybrid models. It's a mind boggling, anyway. That's a new one is coming up. It's concierge medicine. People want to get paid and they write a check and get out of that process. Like India almost is a concierge medicine, is patient pays the bills. The three models. Now there is a very new thing coming up in the concierge model, is a direct primary care. So primary care is just probably you don't, eventually in the future, primary care is not covered by insurance. You're going to pay from your pocket and then go to the doctor and get paid. So you pay from your pocket, or if you cannot afford to do that, Medicaid will cover that. That is going to be the future of the care in the primary care, at least. The next one is, I want to tell you the Medicare payment plan. You need to understand a little mathematics. So you need a really quantum physics background here. So it's what that I will give you some kind of just a hint of that in the surface analysis of the Medicare payment structure. So if you suppose you bill $100 to the insurance company Medicare, they will authorize you $80. Okay, that is very strange. So you can bill anything you want, but I tell you why they do that is a very complex system to keep the profile up. But the reason is they bill $100, they authorize the $80. Medicare says that you're authorized to get $80. Then actually they pay, out of $80, they pay 80% of $80, $64 they pay. They won't pay the entire $80. They tell you go and collect from the patient that 20% of the money that you need to collect from the patient. So patient must pay $16. So that is the responsibility. That's where the lot of things go right and wrong. So you have to bill the patient. The patient has to pay that $16. If they can't afford, they can go to Medicaid. Government insurance can pay, and government say, I'm going to pay you $10. That's it, end of the story. So patient may be paying on an installment basis. So it's a very complex process. It is a mind-boggling, mind-twisting thing in this one. So I'm giving you mathematics behind the Medicare payment plan. So most of the insurance follow this kind of a structure. So then self-insured, there's a lot of companies are now in the Silicon Valley, you find it, they're self-insured. IBM, for example, and Macy's, they have their own insurance company. They don't need anybody else. They don't go to the insurance company. They maintain, they hire a TPA, third party administration, they hire. That's where Indian call centers, everybody comes in pictures, third party administration. And then they cover their health of the patients. This is a very attractive model if we understand very well the risk analysis. So what they do is after a particular amount, like a $25,000, suppose a patient has a cancer, then these companies will reinsure. The Lloyds of London, they go to a big insurance company and say, if my patients go more than $25,000 cap, then I will, you cover that up. So they pay reinsurance fee for big companies. So they self-insured people, or there are a lot of companies are self-insured. Even small companies are starting to doing self-insurance. There's a risk retention groups, they call. So this is a very good model. So a lot of direct primary care is very useful for the direct DPC, direct primary care, the model. So a lot of people ask you, what is Obamacare? Everybody talks about Obamacare. I'm just giving you, it's called Affordable Care Act, passed by President Obama. Obama passed it, Obamacare. So it is actually, it is where the doctors got into trouble. I tell you why. It is what they did was in Affordable Care Act, they created a disease protocols. So when we have a protocols, it is a breakfast for Silicon Valley. So they don't need a doctor anymore. They can use the computers to do the protocols. That's where Silicon Valley onslaught on the healthcare field. When they define the Affordable Care Act, clearly define the disease protocols. So, for example, somebody has a diabetes, and say in 3 months you won't see A1C levels, you got to check, and then you have to do EKG after that. So these are the clearly defined protocols. If you deviate from that, they will find you. They will find the doctors. So this is the system came up, but there is advantages too in the Affordable Care Act. Is 80% of the money they need to spend on the medical care, so they cannot spend on the bonuses. The 50% of the bonuses they cannot spend their money, the insurance money they cannot spend on their bonuses. They have to spend on the direct primary care, direct medical care, 80% of the money. Well, there is a lot of twists and turns on that, but that's we can talk later on about that. But the second one is in Affordable Care Act was, this is covered by individual mandate. Everybody has to covered by insurance, otherwise they fine you. That is the Obamacare says that you have to, if you cannot afford, they will provide you basically expanded Medicaid program. That is basically okay. That is what the Obamacare is. So if you cannot afford it, they provide it, or if you don't get it, that's they charge you. But the company is having a problem, so their insurance premiums went up quite a bit. That is the pros and cons of the Obamacare. That's one of the thing is bigger problem there. The insurance premiums went up. But one of the crown jewel of this thing is the one of the things is in the Affordable Care Act is pre-existing conditions. They took it out. In the United States, you would not believe this is a lot of other people get shocked. They can insurance companies can discriminate. It depends on the disease that you have. So why do you need insurance? What is the risk analysis they're doing? So they're discriminating you on the basis of you as a human. So you get the diseases. So they're trying. That was a big change. Obamacare. That is the biggest plus for the Obamacare. But there is a cons. A lot of he did not do the Obamacare. Did not do the tort reform. Legal reform is not done yet. So there is a lot of problems there in that sense. Value-based care, he proposed a value-based care, but it came the one of the value-based care is, for example, I told you that what is outcomes of that? How many suppose what are the outcomes based on the outcome? You know, so it has a lot of intricacies of there. It is a very complex the way it is designed. It is when there is a complexity, there's always prices go up. That's what my feeling is. So it's a good and bad. So the Trump came in and he passed one of the crown jewel of his administration. How to give you a fair, Republicans and Democrats, they did something good, both of them. For example, in the Republican side, they did the price transparency rule. Price transparency rule is you have to publish all the prices of every procedure, quantifying the healthcare system. That is a first and foremost requirement in the Trump to in order to create a competition. In my view, my personal view is, that Medicare for all is not, you may say that people like it, but Medicare for all is good and bad. I tell you what is a I go back 1 second. Medicare for all is one of the things they're talking about it, but America is based on innovations. We we can create innovate. America is a forefront of innovations. They created all these things that they created. I think a free market system, fair market system, can really work good for the patients, in my view. Free choices. They say that there's a business, you're doing a business with the with the patients, but it's not a business. Business is that you're giving all the choices, better choices for you. That's, in my view, free enterprise system. Actually, what we have is not a free enterprise. Is carved out by big boys, big companies, so carved out these geographical based areas or patient classifications area. So they classified that. So it is basically Medicare for all, good and bad. That is a one area. There is a political hot debate right now in the country. So what are the agencies? They take the laws in is a particularly there is a laws. They run the particularly two major agencies: FDA and DEA, Federal Drug Administration, Drug Enforcement Authority. These two agencies run the basically all the laws. And there's a lot of federal, state, counties, private parties. There is a huge number of things are involved in the regulatory as, areas. So one of the main laws is tort clause. A lot of healthcare entrepreneurs don't understand this law. Is the inducement of referral. So this is a Indian style, doesn't work. Oh, my brother-in-law got some money. I didn't get the money. So inducement of referral means you get a benefit. You or your wife or your relative gets benefit. That is under the tort law. You cannot get benefit one way or the way. So it is very, you cannot give money back to the doctor because you're sending a patient to you. That is a tort law strictly prohibits that. That is a criminal and civil laws for that protects the patients. So this is a big thing and missing in India. There's no stock loss. You need that in India to actually a comprehensive healthcare system. You need a stock kind of a loss that is required in India is stock loss. But some of them are the stock laws are very strong in the United States. The next one is Hipaa privacy laws. In the Privacy Act, there is a Patient Privacy Act. That's basically it is designed to actually mostly it is a patient the data privacy. The data privacy is in the transmission. During the transmission, people or Russians that can access to all your privacy, the all the patients records, and give it to a competitor or something like that. So they created a patient their laws that created this protecting the patient's privacies, so they can prosecute whoever violates that. So this used to be prosecuting the doctor or somebody, but not anymore. They cannot sue the doctor. Hey, you you gave to somebody by mistake some kind of a the information. So they cannot sue the doctor. It has to be HIPAA laws. That is a federal law that they. So it is basically protection to the doctors. In fact, you know they don't know that it is a protection to the doctors. You cannot sue them because of the privacy laws. It is a law governed by the federal government. So whoever the culprit is, whoever publish those things, they can prosecute them. You know. So that is a key. That's a HIPAA laws. Or there's a Patient Rights Act is also part of that. There's the prescription laws, pain pills, for example. They prosecute a lot of doctors because of that over-prescribed pills. All this Drug Enforcement Authority usually oversees that process. Antitrust laws are malpractice. So you cannot say to block out somebody to fairly compete. They don't enforce it very well, but that's one of the antitrust laws. Or anti you have to allow the competition to go in that market. You cannot stop the competitions. Basically, antitrust laws are. So these are the malpractice laws. There are several laws. It's just mind-boggling. There is a huge regulatory bodies in this one, but sometimes over-regulated, sometimes less regulated in this whole thing. It is very complex to understand. But so so a lot of medical devices, they ask me Silicon Valley what they need is the first thing is you have to go to FDA approval. You cannot use a medical device or an app. They think, oh yeah. One guy came to me one day, oh, I created an app for the drug dosage for the cancer patients, and it is an app. They can use, anybody can use it. I said, did you get the approval for FDA? I don't need approval. It's a math. It works. I said that you need to you need to get approval, my friend. Otherwise, you get into trouble. And then I didn't. He doesn't know that. They don't know. They think that anything they come up with on their computer works, and if it works in the computer, so it's okay. But you have to get the FDA approval. There's a 510K approval that is a pre-market notification. Basically, there is existing. Suppose I'm creating an EKG machine. Is already EKG protocols are already there, so they give a faster. But in fact, they say faster. Don't expect that fast. Government, it takes at least till 6 months to 1 year. It's not sometimes when 2 years. It's a faster than a FDA approval for the drugs. That's all it is. Is a little bit faster, but it's not. You have to. There are a lot of things there. Medicaid approval. You have to. Then after that, it's not enough. If you invent a app or if you have a device, it is not enough to get FDA approval. That's the first step. The next, to get paid, you need to get a Medicaid approval. If the why Medicare? Even though you don't see Medicare patients, Medicare is the standard guidelines, standard Bible for the insurance companies. If the Medicare doesn't approve, the other insurance companies don't approve. So you need to get first thing is Medicare approval. So the private companies follow. Very unusual. Private companies approve it to you first without the Medicare approval. So you have to get the Medicare approval. Then after that, you have to go to individual insurance approvals, each one of them. You have to go through. So it's not a straightforward process. You think in the United States, a lot of people coming from other countries, they invented something and they think that they can revolutionize the healthcare. They don't understand the regulatory bodies involved in this whole process. It's a very complex regulatory process. Then, so when you design healthcare entrepreneurs come to me and say, I'm giving you a warning to them. This is the first thing they need to ask this question. Who pays for your app or device? An insurance, a doctor, or a patient? Insurance companies never pay that easy as you think. They're not going to shell the money first for things that they're still experimental, things that you can revolutionize in your mind. You have to convince them quite a bit. Doctor definitely doesn't pay. I can tell you that. Patient is most of the people cannot afford. Patients cannot do that. So these three areas you will not get anywhere. It's very tough to go through the process. You have to go through the previous screen Medicare approval process. So only people paying for this whole device for your app is your brother-in-law. That's what at the end of the day it stays up. So don't dream up that some of the app or some of the device you immediately get paid. It's a long process to work on that. So thank you for listening. This is basically I'm giving you a basic idea about what the insurance companies are. You have to go and investigate and read more about it yourself. A lot of people ask me these questions. That's why I give you a rundown of the basic ideas. And now, so you can follow me on Twitter, Ramana Universe. LinkedIn, I have Medbricks, linkedin.com/Medbricks. You can see me there. So I'm going to bring Dr. Krishna Tangella. He is a distinguished professor of pathology, and we can learn from him. It's a fascinating discussion I had. We can ask him questions about pathology in the what is the stages of the pathology in the what stage in India, particularly. We are from India. I want to ask about India and other parts of the countries, other parts of the world, pathology situations. Let me bring him to the table. Dr. Krishnan, welcome back.
Thank you.
I gave you a rundown of the insurance companies. people think that a lot of entrepreneurs come to you probably a lot of times, and then then ask you the same questions. You get tired of answering the same questions. You have to go through all these processes. They won't listen. This is a standard thing. Go through this process and come back to me after Medicare approval or all these processes after you finish it.
Very true. You did a very good presentation, by the way.
Thank you, sir.
Summarized it
Thank
very well.
Thank you, sir. But anyway, such introduction is nothing about medical. Is I'll tell you regulatory process that is people, Silicon Valley people don't understand it a lot of times. They think they understand it. That's why I gave. But anyway, so fascinating. The one you're saying, the advances in pathology is impressive. The DNA side, the molecular genetic side, it's a blood side. All of them are improved tremendously our really care system. So I think the loss of investments will go eventually finding that area, particularly if you are talking about the diagnosis and the treatment and the prognosis side of it. So every area that the pathology is involved. So how other countries like India is doing that in that direction in the precision medicine wise, or particularly in the pathology advances? Are there any you see? What is your opinion in those areas, and what are the things that are needed in those countries? India is one of the examples I'm asking.
Sure. So I would start off by saying that I've left India almost 30 years ago, and I really don't. And I became a pathologist in America. Um, I did not have any pathology training in India, so I wouldn't know the inner workings of how it works in India right now. But I do have some of my colleagues from medical schools who are pathologists. I do have colleagues in India who are pathologists. I have interacted with them um, when some of my relatives were going through a tumor slash cancer diagnosis. Um, I can tell you the quality of pathology services in India, in at least in the big cities that I've observed, is top notch. They have the equipment, they have the brain power, they use current standards. They're very, very good. Um, Now, I really don't know, away from the city in semi-rural and rural areas, what is the pathology infrastructure when it comes to laboratory medicine. Um, uh, so I wouldn't know that. But I can tell you, I was pleasantly surprised when I went to some of the bigger hospitals in Hyderabad. Um, the quality of pathology services, their pathology operation, their teaching programs, they are just absolutely top notch. I was very impressed.
Let us talk about a little bit about your venture, DoveMed. What just to give introduction to this is a medical website, the information website you started it. So let us talk about that a little bit, 1 minute about that.
Sure, thank you. So, um, DoveMed is, I'm a founder of DoveMed, and DoveMed is a healthcare um, ecosystem where we have multiple applications and programs that brings together the physicians and the patients um, in an ecosystem. And we have multiple products where we have designed for patients. We have multiple products we have designed for the healthcare providers, such as doctors and advanced healthcare professionals. And we also have in our ecosystem uh, businesses that are related to healthcare, non-for-profits that are related to healthcare, uh, hospitals, clinics that are related to healthcare. Um, it is it we have launched these products. They're operationals. We are Some of them are in beta phase testing, but we are rapidly advancing to uh, to market where it can be used seamlessly in a version that I like. Um, and we expect to change the world a little bit in healthcare system through government.
You're welcome to come back anytime, talk about DoveMed specifically. But thank you. It is true honor for me, sir, to talk with you. You're distinguished from my neck of the woods you came from, and then you're really, it's truly an honor. Thank you, sir. Thank you
It's a
for
great honor to be
joining
here.
us.
Thank you for having me here. Have a good evening.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.